नहीं आएगा छोड़ो वो नहीं आएगा तो शुरू कर दो सेशन ऑलरेडी
Good afternoon to all. Welcome to all those who have joined this session. Greetings from NITRE E-Niti, Nurses' Efforts to Eliminate TB in India. To strengthen the nursing fraternity of India and to keep update in TB, E-Niti conducts training and upskills the nurses of the different healthcare systems across states. Moving knowledge without moving people became more critical than ever before. This platform brings together healthcare providers, subject matter experts using video conference technology, brief lecture presentation, and case-based learning. For all those who have joined newly, I am Shima John, moderator for today's e-Niti clinic, and I am from our institute, NITRE. This is our 14th session, and the topic for today is administrative controls of airborne infection. We conduct this clinic last Friday of every month, but due to some unavoidable circumstances, we preponed for today as the presenter wasn't available for Friday. The major milestone is distribution of certificates after each class to all the attendees. You are requested to kindly join separately and not in groups. Otherwise, you won't be able to get your certificates. Initially, it was for the nurses from our institute, but later, after its official launch, it has been made public with an objective to share and expand the knowledge with the vision to involve other institutions as learners and as well as presenters. I request all of you to please join separately. Now, let me introduce our dynamic team here with us. Our case expert is online. Ma'am is Martin van der Walt. Ma'am,
unmute.
Good afternoon, ma'am. You can hear us?
Yes, good morning.
Good morning. Let me introduce you, ma'am. Marty Vender, ma'am, is from South African Medical Research Council, South Africa, and is the director of the tuberculosis platform. She is trained as microbiologist and holds a PhD from Sefako Mercato University, South Africa. Marty, ma'am, has joined the Medical Research Council in 1998 and has done 3 large-scale nationwide surveys in the country: drug resistance survey, line probe assay, and the SATB prevalence survey. Most recently, she has served on the Green Line Group, the WHO, and is the member of South African National Government Policy Advisory Group for Infection Control. Ma'am is also serving on the Stop TB Partnership for End TB Transmission Working Group since 2017 and currently serving as the Vice Chair of the ETTRI. She is serving on the TB Prevention Working Team of the South African Tuberculosis Task Force, a policy forum that advises the National Department of Health on TB control policy and practice. Research focusing areas include the epidemiology of TB in South Africa, prevention of TB in high risk and priority populations. More recently, her research on the transmission of airborne infection expanded to pandemic preparedness of the health system. We welcome you, ma'am. We welcome you to this session.
Thank you very much and good afternoon.
Good afternoon, and thank you for joining us as expert. And next to me is our nursing superintendent, Dr. Anita Rani Kansal. Dr. Anita, ma'am, has been master trainer for training of nurses in TB by ICN. Ma'am has been recognized by the ICN TB MDR TB project as a leading light on recognition of her outstanding contribution to the care of people affected by TB. We welcome ma'am to this session.
Thank you.
Welcome you so much. Next to her is our CNE coordinator, Ms. Sakshi. She is also from our institute, NITRE. We welcome you all to this session. Now, moving on, let me please request you all to mute your microphone so that there is no distractive noises. I hope you all mute your microphone. There may be technical interruptions, poor audio quality for a short time, but keep patience. And do not do multitasking and keep focused on the session. I welcome you all again. Now we're going to start the session. Ma'am, over to you.
Thank you, Shima, for nice words. Thank you, Marty ma'am. Thank you so much for being with us for this hour. And your expertise, our nurses will be very grateful and it will be very helpful for them to have your expertise in this. You are such a senior person in so much of research and in TB work. So I think your expertise will help us. Thank you. So I'll start my session.
Thank you very much. May I every time ask you to just share the slides or move them on. Can you again share the screen, please?
Yes, ma'am.
Good. Yes, thank you. Thank you very much. And thank you, everyone, this afternoon for having me. It is morning in South Africa, and I hope you've also got a very wonderful day. Thank you very much. So the topic that I'm talking today is strategies of airborne infection control in TB healthcare settings, administrative controls. If we can go to the next slide.
Yes.
Ma'am, excuse me,
Yes,
ma'am.
ma'am.
Ma'am, actually, you are the case expert for this, and she is going to be the presenter.
I will present, ma'am. You have to take the doubts, and our doubts you have to
clear the doubts of this learners here.
Pardon, could you, is it good for me to start now, or do you first want another case presentation?
No, ma'am, it's after presentation. Actually, our nursing superintendent ma'am is going to present the case, and you have to be the case expert for this. Anyone from the learners may have doubts after this session, so you have to clear their doubts, ma'am.
Good, good.
Okay, ma'am?
Yes.
Am I clear now? Thank you, ma'am. Thank you.
Thank you, ma'am. So this is the second webinar from the series of airborne infection control. Last seminar, last month, we have just seen what are the basics of TB, what are the cough dynamics, what is the ventilation, what are the air changes per hour, how the ventilation should be in TB setting and in the normals of this thing, and the methods of airborne infection control. So this was all that we have discussed in the last month's webinar. And today we will talk about the administrative controls of airborne infection control. Next slide. So there are mainly three controls: administrative controls, environmental controls, and respiratory controls. So today we will focus only on the administrative controls, what it is, how this can help in infection control, and what practical implementations we have done at our institute that we will be explaining. So in the airborne infection control, the first priority is the administrative control. First, what is the meaning of first priority? Means it will have the maximum impact. And second is the environmental control. That means we will do some methodology by using fans, exhaust fans, or vacuums so that we can reduce the concentration of infectious droplet nuclei in the environment. So that is the second priority. And third is respiratory control. In this, respiratory control means we protect the healthcare workers and we give them masks N95 so that they can be protected from the infectious material, and that will be the third priority. So the most important and the most, I should say, effective method is administrative control. So we will see all about the administrative controls. So what is meant by administrative control means all the action that is taken by the administration to reduce the risk of transmission of infection. All policies developed by infection control team. All policies developed by infection control team to decrease the risk of transmission of infection, procedures for implementing, enforcing, monitoring, evaluating, and revising the infection control plan, who will do it, where it will be done, who will be monitoring it. So these are all will be covered under the administrative controls. So why should have this? Because this will have the greatest impact. For example, in NIT we are having the OPD of the HIV patients and the TB patients just adjacent to this. As we know, the HIV patients, they are likely to get the TB very much. Even then, we had the mixing of those patients. So ultimately, in the administrative control, what was done, that a separate building was made for the HIV. So that means that is reducing the risk so that the HIV patients will not get the TB. So this will have the great impact as compared to giving the N95 mask to HIV patients and other. So serves as the first line of defense for preventing spread of tuberculosis in healthcare settings. It can be implemented all levels of healthcare, both inpatient and the outpatient areas. So this is the present scenario. This one is our hospital OPD and one is very general hospital of New Delhi. So this is the picture from there. You can see the rush. You can see the crowd at the registration counter where they have to register. So if even a single TB patient is there with coughing, and how many others can be infected, we can just see it. So we need to have administrative control at such areas very meticulously so that we can prevent the other patients with other diseases. They will not be getting tuberculosis. So what was the learning from the last slide? What we can do to improve all this appointment system? As in our India, we give in the private sectors, they give the appointment that each patient will be given for 15 minutes. So the OPD rush or the waiting time will be less, and the rush in the OPD or the waiting area will be less. Then screening for the cough. Anybody who is coughing, who has any symptom of cough, they should be segregated and given a separate line or separate queue where they can be screened fast. Segregation and early consultation, so they can be consulted on a priority basis than other patients. Then waiting area for the patients with cough should be separate. Then there should be proper ventilation and mask provision should be there. In our hospital, we have made a policy that any patient who registers in our OPD will be provided a mask free of cost. Then announcements that they should be having the cough etiquettes, the cough patient should be separated, their line is separate, like that. So what else we can do in the administrative control measures? Developing and implementing a written TB infection control plan. That should be a policy that what all has to be done, who will be doing it, who will be monitoring it. Then ensuring the availability of prompt laboratory processing, testing and reporting of results, because this is very important. Till the patient is not diagnosed, patient will be infectious. Once the patient is put on treatment, within 10 to 15 days, patient will become non-infectious. So the diagnostic part is very, very important and it has to be given most priority. Then ensuring proper cleaning and sterilization and disinfection, like in the wards where the patients cough, so proper cleaning and sterilization, that is a must part. Educating and training the healthcare workers to wear masks, to maintain hygiene, to wear N95 properly. There are so many things that we have to teach to healthcare workers. Then calculating and monitoring air changes per hour, air handling units, change of HEPA filters. These are the important issues that has to be seen. Then patient education, that how they have to cough, how they have to protect their family members. Then sputum collection. Sputum collection is very, very important in a TB hospital because that is a major source of infection. In our hospital, we had a thinking that we should be, it was confided in a small chamber. So we thought in that chamber bacteria will stay there only and we will kill it by using ultraviolet lights and other method of disinfection. But we were wrong because there was no ventilation. But ultimately, when the patient used to go, there was no time that we can sterilize it. So the next patient goes because there is a lot of rush. So ultimately, it was in the administrative control, we made an open space at the outside of the boundary where the sputum collection was done. Then triage and evaluation of suspect TB, that's very important. Even it should be done with the active screening at the community level. Then reducing the exposure in the laboratory. It's very important because in the laboratory, maximum percentage of probability of infecting the lab technician is there. So usually in the labs, we have a special BSL-3, BSL-2 labs where the vacuums are created within where the sample is being processed. So in patient management and isolation policy should be there, and meeting for the discussion of gaps, that there should be regular meeting of the infection control committee, and they should be discussing the gaps and how to resolve it. So administrative controls, international guidelines are that first you have to screen, then you have to screen. Screening means all the patients should be screened for cough and any symptoms of TB. Then educate the cough hygiene, then separate the patients in the well ventilated areas and give masks to cover their mouth and nose. Then provide services, triaging system, then testing, diagnosing it properly and fastly, then investigate or refer the refer for TB or refer the patient. Next. Now, how to implement next? No, it's okay. How to implement the administrative control measures that we will see in the next slides. Like we can have a separate screening counter where we can have the advertisement or the posters or announcements that anybody who is coughing, who is having this symptom, please come to this row, or we can assign someone at the gate like the guard or the security check that anybody who is coughing should be into this line at the registration counter, so that there is no mixing of the TB patient with the other patients. So screening after registration, that should be fast track, so that they are consulted. Their consultation is done very fast, and they are sent out of the hospital or out of the system very fast with proper education and medication and up taking the samples, etc. So health education by posters or we have a special here in NITRD, we have a special unit that is of health education, where we have a health education officer and 6 health education visitors. Those who regularly, this is the posters from our hospital only, where they each and every patient is being counseled. Whosoever is diagnosed as a TB patient is being counseled for adherence, for cough hygiene, how to protection, and about medication. All these are the counseling is done before starting the treatment. This is a separate sputum collection area. This is also near the boundary, that so that in the open area there will be lot of ventilation. So whenever patient gives the sample, that will be, so with the air and or ventilation, that will be diluted. So we should have a separate well-ventilated room for aerosol generating procedures like bronchoscopy. Here, what we have done in bronchoscopy, we have put the UVGI lights in suctioning. Person should wear the N95 mask, sputum induction and nebulization treatments also. These are the procedures where the aerosol will be generated, and anyone who is caring the patient is at more risk of developing the infection, and this will be, the bacteria will come into the air. So these areas need special attention about the ventilation and airborne infection control. So segregation, we have to keep the HIV. As I discussed that we had a separate ICTC and ART center. This is our hospital's separate ICTC and ART center. So keep the HIV persons safe from persons with MDR TB or from the sputum positive patients. Keep infectious TB patients, newly started patients on the newly started drugs away from others. So this is just a case scenario. Anybody, you can write in chat that what will be the answer. A nurse A on duty in crowded TB OPD observes a middle-aged man coughing frequently and is looking weak and sick. He tells her that his mother is suffering from TB and the MO asked him to get evaluated for TB. What steps should nurse A take in this situation? You can write in your chat box that what all steps as a nurse you will take if in the OPD you see a man coughing and giving the history of TB to his mother. We want answers in the chat. Next slide. Yes, cough etiquette is important, that they should cover their mouth or with mask should be there. What else? Yes, of course, should be evaluated, but what all you will do? Segregate the patient. Yes, you take the patient to a separate counter or get the patient examined quickly at the priority. Yes, Payal, you are right. Anybody else? Shifa, next slide. So the nurse A should suspect that the man has an infectious TB. She should ensure that he is evaluated quickly. He should be provided with a surgical mask and told to cover his mouth while coughing and sneezing. Nurse should ask him to wait in an area away from the other patients. So what all practical implementation, actually when we were trained by the CDC for the airborne infection control and the International Council of Training, then we implemented so many things at our hospital that we were not knowing or we were not having that that intent or that practical information. So whatever we implemented, that I'll just share in next slides. So our infection control committee headed by our senior microbiologist, and they take care of both airborne and other infection control measures. And we then have a segregation of TB and non-TB wards and MDR wards. This is one of our MDR ward where we have a CCTV and where a nurse can see or all the patients at her duty room. So then healthcare workers protection policy of staff rotation and TB and non-TB wards. Then we made a policy that a one staff nurse who is posted in the MDR or TB MDR ward, she will be rotated to other wards after 6 months. The policy of staff immunization and regular screening for TB and regular training of the employees. Action taken in the wards is the rearrangement of furniture, means there were big windows. This hospital is made almost more than 70 years early. Oh, this is 70 years old hospital, and we have a big windows where we the air exchange is very good. But because people were not very much aware, so they have put a big cupboards or almiras just in front of that. So we did rounds of those wards and did the rearrangement of furniture so that the better ventilation can be done. And even that mosquito mesh or the wire mesh that was full of that proper cleaning was not done, that full of dust and all, then regular wire mesh cleaning was done, and this also increased the ventilation. Then regular cleaning of small ventilators and the exhaust fans, providing PPE to staff and the patients, and then we had checked the exhaust system also. So this is a sputum collection area. As I have told you, then we had a closed chamber, this hexagonal sputum collection chamber. This was close to OPD and where patient used to go in and used to give sample. But ultimately, this was seen with the cultures and all that we are not able to sterilize it. So after that, a new sputum collection chamber was made that was open and that was near to the boundary. So this is our OPD, and this is the center of the OPD. At the four sides, there are rooms, consultation rooms, and the patient waiting area. And this center is all open at so that there is better ventilation of the air. These UV lights have been put at the patient waiting area, bronchoscopy, operation theatre, radiology, where closed area. These UV lights have been put in our hospital. Then we have a setup of health education department. As I told you, there is one health education officer. There are health educators. We have 6 health educators, those who counsel each and every diagnosed TB patient, and they go to indoor wards also to give them health education regarding cough etiquettes, how to dispose of sputum, how to protect themselves and their family members. Health talks regarding cough hygiene, nutrition, regular follow-ups of the patients, nurses, and health visitors, regular fumigation of the special units like dressing room, minor OT, ICU, then yoga facility for the staff and the patients for better immunity and well-being. So in the next, this was all about the administration, that what all actions administration can take to improve the airborne infection control. And in the next, we will be covering the environmental controls and then the respiratory control. So in the month of May, we will have environmental control, and in the month of June, we will have the respiratory control. So this was all about just a recap that what all administration can do. So that is the best method of airborne infection control prevention. So we should mostly focus on the administrative controls. Thank you.
Thank you, ma'am. It was a super wonderful presentation. I think all the learners must have now know about the management, how to control, how to prevent TB using administrative controls. I think it's a major thing that until the administration gets in, we won't be able to manage TB in wards. Thank you. Ma'am, Marty ma'am, can you hear us? Ma'am, can you hear us?
Yes.
Ma'am, can you please, do you have any key points to add on, or you have to elaborate something on this topic, administrative controls of TB?
Yes. Thank you. Can you see me and hear me?
Yes, ma'am, you're quite audible.
We can see you, we can hear you.
Thank you. Good morning. So,
Ma'am, one more. You're beautiful, ma'am.
You're very beautiful, she was telling me. She's so beautiful.
Thank you. Good
Okay,
morning.
sorry.
Yes. So, thank you. And my comments are very much in the order of the presentation that you've given, a very, very well presentation. So if I might ask if we can go to the second slide of the presentation. I want to comment on that, if you please, just the second slide, please, of the presentation. Oh, yes, that one. Or let's go to this, as you have done the air changes and all of that, let's go to the second slide. So I want to talk about the second slide. If we see at this level, and it's very much what we call the infection control triangle of this. And as we can see, the administrative control is the main one, or the basis of any infection control in healthcare facilities. And it doesn't really matter if we've got respiratory control or environmental controls, and we haven't got the administrative controls in place. The administrative controls are very important so that can you hear me?
Yes, ma'am.
Yes, ma'am.
Good. So the administrative controls are very important. First of all, they are there to protect our healthcare workers. But they are also there, and as we know, there are many people, accompanying people, family members, many other people coming to visit facilities. In hospitals, there are visitors. And so all of that, all those administrative controls are actually there to protect each and every one from tuberculosis or from TB airborne infection in all our healthcare facilities. So the administrative controls, and we've seen through the presentation, is one of them. The backbone really is to have an infection control policy there. Now, in South Africa, we've always got very good policies, and in India as well. However, in South Africa, we find implementation of the policies are sometimes lacking. Sometimes there's not an infection control officer, and that person really could stand alone. It's a management responsibility. That person could really stand alone from the TB program. But so first of all, the policy is there. The policy is there in one sense to have patient flows so that we don't have, in South Africa, we've got a very high burden of individuals with HIV, and they are, of course, very susceptible to TB. So first of all, it is all if we've got other people with immunocompromising conditions, for example, cancer wards, so that we don't have many groups of patients which might probably have TB passing through through those sessions. So the administrative control is very good also for queue management. So I want to go to, so first of all, the administrative controls, the policy should be there to manage patient flow, but then also for the healthcare workers. And we know that healthcare workers are actually what we call a special population in terms of TB control. Now, we don't really know in many countries what is the burden of TB amongst healthcare workers, as they are usually, we haven't got a good surveillance system of them. How are we going to do surveillance on them? And if a healthcare worker suspects coughing tiredness, that there could be probably tuberculosis, we do not want, so we do not want that person to go to be screened for tuberculosis. That person might quite often then be identified, diagnosed with tuberculosis, and we need to recognize a level of stigma of privacy. So if we don't want our healthcare worker to stand in the same queue as the patients they treat, so where will they go to get their TB treatment? So administrative controls, they can be good, but I do not think they really address the needs of healthcare workers. Now, in South Africa, we've got some figures on TB in healthcare workers. In essence, they contribute to 1%, we believe, probably, to the burden of TB. Now, 1%, one can say, isn't much, but there's overall a workforce crisis amongst nurses. We do not have enough nurses. This is an occupational disease. So we also need to give our nurses time off to also side effects and all of that. So we actually just, if the healthcare worker gets TB, first of all, there may be others in the clinic that also have TB. And with a healthcare worker, and I think in South Africa, we sit with a very difficult issue. TB in a healthcare worker, well, is a notifiable disease, but all of us know when a person presents with tuberculosis, it's really very, very difficult to determine where infection took place. Now, the same in terms of compensation in South Africa. How do we say that this person contracted TB in the healthcare setting? So that's the one problem. But if we haven't got administrative controls, with other words, triaging of patients, it's not going to help that we've got UV and open window policy. First of all, the basis is so that any individual visiting a healthcare facility should wear a mask. it doesn't matter where. And then also our nurses should wear an N95 particular respirator, because that respirator need to seal very tightly here, so that there's no TB organisms coming through. But it has been shown that if a coughing person, wears a normal surgical mask, that velocity of the TB organisms that will be expectorated is immediately most of them happens in a mask. So the amount of organisms that gets released in the air is immediately decreased. So please can we have go through the next slide. And there I also want to make some comments. If I can see the next slide. I think that one is, if we see airborne infection control, first of all, we have got the administrative control. It's the first priority, and the purpose of that is to reduce exposure. So make our healthcare facilities, hospitals, make them safe. We've in the COVID time, I believe it absolutely raised the profile of the almost a dangerous working environment for our healthcare workers. And I think the one behavior that COVID brought to us, we as healthcare workers, it's almost as if healthcare workers in TB over the years really struggled to get attention. But with COVID, and in South Africa, wearing of masks has become acceptable in any setting. So I mean, even for me or my family members, if we go to a shop and one believes we've got a cough or anything, it is quite natural now for us to wear a mask. So there are no more stigma around masks. And then, of course, COVID also taught us that if one has a mask, please see that you do not be close to other people. And then the whole issue, and you made very good presentation about that, is the issue of cough etiquette. Please cough in your arms. So the administrative control is very important. Unfortunately, it came after COVID. After everyone has become aware of COVID. And it's, of course, for all of us in TB, really a very, I think it's a very sad lesson, and all of us might actually feel that TB was declared an health emergency around 1990. HIV is seen as the first global pandemic in modern times, but still we do not hear tuberculosis as an ongoing disease through the eons, that we don't get the same level of importance. So if we then look at the respiratory control, there we see protects healthcare workers, especially in areas where concentration of TB can't be reduced. Unfortunately, with TB and airborne infectious organisms like measles, like flu, and we talk about pathogen X. Unfortunately, we will have a pathogen X, which is most probably airborne. So all of us know that an area, we can't say this is in terms of safety of air. This is a clean area. We don't know. Air need to breathe by everyone. Water usually is, if water is unsafe for use, unfortunately, diarrhea is a disease, and we very quickly go to, and food poisoning, we go to a doctor and there's a crisis and the source of that infection. But air, everyone breathes air. And we know that if we want to make an environment safe for air, we need to have, first of all, ventilation, cross ventilation. And if we look at the environment where our healthcare workers work, we want to give to our patients some privacy, so the one door need to be open, and sometimes the other window really, if there's another window, we can't open it in bad weather. So we do not need where TB, we do not know where TB is. It can actually be right through our healthcare facility. So I please want to go on through some of the other slides. I don't want to talk to them, but if you can please give me the next slide. Okay, we've spoken about the administrative control. So I've discussed policies. Policies are very, very important. A part of the policy should be how often are we going to screen our healthcare workers? And why? And as I've said, it's most probably to have the greatest impact on our healthcare workers. As we want to protect ourselves if we haven't got them. So it is the first line of implementation, and it should be implemented all through facilities. But healthcare, our policy, infection control policy, which means surveillance of healthcare workers. I've said there are very difficult methods of surveillance, but then, or testing healthcare workers. In South Africa, we've got just recently again have a new policy for infection control. Now, the whole question is, do we have a surveillance system? And I'd really like to know if India has a surveillance system where every healthcare worker that develops TB is being recorded. Then how often are we going to screen healthcare workers? Theoretically, if a healthcare worker joins a facility, and then again when they exit the facility. But how often are we going to screen healthcare workers? Now, there's in other countries, testing of healthcare workers for underlying TB is testing with an IGRA. We don't use Montu tests anymore, screening them with an IGRA, and if they've got a positive IGRA, we would give them IPT preventive treatment. But in a setting like South Africa and probably in India and many other high settings, and we know that almost a quarter of the world's population is latently infected with tuberculosis. So in South Africa, we not at all test for latent TB. Now we've got a very grand algorithm for screening healthcare workers and active case finding, and much of what we want to do actually emanated from the TB prevalence survey. I think India actually completed their prevalence survey just some time before South Africa had, and we all know now, and if we looked at new screening algorithms from WHO, the asymptomatic TB screening with chest x-rays has become a very, very important tool. Now, I don't know how available chest x-rays are in India. It would be good to hear that you have got it available at the lowest level of healthcare workers, but of the healthcare system. But even though we've got these automated readings, someone still need to take that digital chest x-ray. It still need to be a well-taken image. And then although the algorithms will tell us this person most probably has got TB, quite often it still need to be read by a radiologist. So, and in regional hospitals, we may have that. Radiologists are a very high specialty, I think, all over the world. And we want radiologists to work in the public sector. In South Africa, we really do struggle to get radiologists. So we say that we want at least every 2 years. So it's an gene expert test, and then a chest X-ray, and of course, signs and symptoms of TB. How feasible that can be, we still do not know. So I'd like to hear from other countries if they really got a surveillance system, if they track the healthcare workers where they are. So if we can go to the other slides, please. Oh yes, this slide of India, please do not feel that this is a slide of India. It's a slide of South Africa also. And I think the problem that we have is that, first of all, the healthcare facilities were built many, many years ago. And it's not now easy to say, okay, now we're going to break out windows or build open areas where people need to sit. It's all very nice to say that when it is cold, it's raining, the wind is blowing, or it is so hot that a person really can't stand sitting outside. So of course we've got long queues, and in South Africa particularly, our healthcare facilities were built long ago. So since HIV, of course, the burden of first of all, we now have many more individuals visiting our facilities, health people either trying to get diagnosed, or if they are diagnosed with TB, to get their antiretroviral therapy, to get their TB preventive therapy. So this is really a slide everywhere. Now we can put in ventilation. Yes, we can, but is cross ventilation sufficiently? If we have kind of these whirly birds, is that sufficiently? To have UVGI, it is a very, very efficient measure. But for example, in spaces like this, how many devices do we have to put in there? UVGI, really the area that they can cover is not very large. And of course, in South Africa, we've got the problem that all government buildings do not fall under the Department of Health. They fall under a Department of Infrastructure. So, and we do know that for UV lights need to be serviced quite often. So in South Africa, oh pardon, I don't know what's the cell phone doing. So in South Africa, they need to be serviced quite often. There need to be a maintenance plan. So UVGI is very good, but it need to be a collaboration with other government departments, and I think that's where in South Africa, unfortunately, UVGI falls short. We can go to the next slide, please. And I think that's a very good slide. And the next one, I think, yes, I've worked through this. I think what we want here, which is very, very important for me, is patient education. Now, we know that TB, there's lots of undiagnosed tuberculosis in communities. That's why we sit with missed TB cases, if we can use the word. I know there are many other, but we almost a third to 20% in South Africa with our TB prevalence survey shows that we are still missing almost 20% of TB cases. So, and I think everyone working in TB do realize that not even patient education, but education of our communities, raising awareness. If one has a cough, all of this, please come to healthcare facilities. And then we, of course, know that patient education is very important, really enforcing. If we can, a person with TB staying lots of times outdoors. Again, I do not think it's feasible. Again, cough etiquette, yes. But we know that a person who presents with TB has already infected many other people. I think patient education to prevent transmission of TB, I think one of the most important aspects is really to enforcing them, do please take all your treatment. So that's, and I think everyone knows that that's probably I think the problem that over the years we've struggled the most with where our ongoing problem with TBs. We can go to the next slides, please. I think that's very nice summary. The next slide. Implementation, I think we can slip that. That's where I've spoken about policy and adherence to that, screening of patients. And I think almost if we've got the administrative controls and everyone patient flow in clinics, that's all good and well. Registration, if we can go past that one. Please past that slide. Fast track, that's yes, that's good. Thank you. Health education, cough education, and then wearing of a mask. Again, this is just to show over the years, we almost, all of us are tired with this message, and it somehow does not reach everyone. Yes, separate sputum collection, I think that we have everywhere. We can go on, and I think you've got very aerosol generating procedures. We know that is a very, very high-risk area for healthcare workers, and if we can go on. Case scenario, yes, well, definitely. Healthcare workers sometimes do suspect that they have TB. Our healthcare workers work with many people who may have TB. And as I've said, sometimes, well, in South Africa, we find that either the workload is so much, or they suspect they've got TB and they've got really almost a fear of TB because they see their patients, how they struggle, side effects and all of that. And keeping HIV persons safe from TB, giving them TPT as soon as TB is being diagnosed. We can go on. And the case scenario, yes, that's good. And then practical implementations, again, the infection control policy. What's an important point is takes care of both airborne and other aspects of infection control. And nowadays, again, since COVID, we know that we need to safeguard indoor spaces against airborne diseases. So TB, we know what happened with COVID, but as I've said, pathogen X will most probably also be. The point that you've made is vaccination of healthcare workers, and unfortunately, we do not have an adult vaccine. We think every one of us working in TB hope that within the next 5 to 10 years, we will have a pre-exposure vaccine, which, apart from children or those exposed, we need to have our healthcare workforce protected. And I think that's my comments, learning lessons from South Africa. And I trust that much that I've said are really known in India. And if you have, I'd really like to know if you've got alternative ways to protect healthcare workers and what measures you've in place, and really if there is high level of implementation and monitoring of infection control policies. Thank you so much, and I've really enjoyed listening to the India scenario.
Thank you, ma'am. You have elaborated all the slides so clearly.
Thank you, ma'am. Thank you for sharing South African experience also. We are more or less same. But just because we are limited to, you have a wider experience of whole nation type experience. But we just have at our institute only, because we are working in the institute. So we don't have much larger view of the whole nation, like what is happening. But in our institute, like the in administrative controls, we have few points that I shared, that we are doing that. Plus vaccination we do not have for the TB, but we are doing for hepatitis B or TT, like that. That vaccinations we are doing regularly for our staff, and annual examination with X-ray chest for all of the staff. That is one policy. That class 4, class 3, we plan a roster and give the dates that everybody has to be get the X-ray chest done at our institute. But that is not for all of India, but at NITRD we are doing this.
Thank you, ma'am, for highlighting all the good points in ma'am's presentation. Well, I just wanted to ask you, ma'am, you told all our good points and all the things which you were lacking in your country, South Africa. But is there any policy which is different from Indian policy that you are implementing in your institute or in your hospitals, other than which is not reflected here in India? Any other policy which you have, so that we can also adopt the same thing here?
Well, our policy is based on the WHO policy. Okay. Precisely that. And as I say, we've got a very good policy. It took us a number of years to write it. In our policy, unfortunately, we do not have other vaccination requirements. And well, what we can learn from you is that I think you've got a very, very good annual screening of that. And I think that's absolutely the best way to go forward. So our policy is very much based on WHO. I think we have a much higher burden of HIV than probably India. So if we look at, of course, a policy of prevention of HIV amongst healthcare workers is completely different. We talk about needle stick injuries and so on. But a policy of prevention HIV is not a policy that address airborne infections. I think that sounds to me that almost the a major difference. We do not test for latent infection. I do not know if that at all is probably what's happening in India.
So in Indian scenario, ma'am, all TB patients are tested for HIV and all HIV patients are tested for TB. That's mandatory. In our hospital also we are doing the same, and this is national policy also.
Good. Yes, our policy also TB HIV is integrated programs. So the healthcare worker, if a person, for example, antenatal care, if a person arrives for antenatal care or simply person is not well, coughing and so forth, then that nurse should, of course, offer HIV testing. And then before we can start, and if a person for the first time arrives for HIV care, person need to be screened for TB. TB need to be ruled out, which can take a long time. And then the person is being offered antiretroviral. And if TB is being excluded, then we offer TPT. Again, if a person arrives with TB signs and symptoms, we investigate them. We do an HIV test. We put a person on tuberculosis treatment and then on ART. So we do need bidirectional screening, and probably nowadays people with immunocompromising conditions like, for example, diabetes. It's all nice policies, and I think healthcare workers, they do know their patients, they do know what kind of care to give. So, but they also work very hard. They've got an extremely high workload. So, as I say, that's the policies, and certainly healthcare workers, I think, do try to follow that as much as possible.
But regarding HIV, all the antenatal cases, any expectant lady is subjected to HIV test mandatory. This is national policy because I go to the various healthcare centers for inspections, for assessments, and it's mandatory, and all are doing that. So every ANC case is being tested for HIV at the first visit itself.
Now that also at start of treatment, but we found in South Africa, once a person, a woman, seeks antenatal care, what we found of those that are HIV positive, usually earlier in their life, they have been tested, they know they are HIV positive, and they are already on antiretroviral therapy. I think almost 70% of individuals, women arriving for antenatal care, are already tested. If they are HIV negative, I think about in 3 months' time, 3-4 months' time, they are again being tested for HIV. We know of cases of seroconversion. The newest policy for TB testing in HIV, well, in pregnant women, actually do say that we need to screen at each antenatal care visit for tuberculosis. That's very important, but we can't use simply gene expert. We know that, say, if it's to an extent early TB, still subclinical TB, culture is actually the best method. And we did find serial testing of pregnant women. We do find through serial testing at each visit, and especially after birth, that we do find TB, and I think it's about 1.6% of pregnant women in South Africa are diagnosed with TB. So, and of course, we all know that TB has a very high risk for the woman, well, for a poor pregnancy outcome during birth. The woman is far more likely to have a maternal death. So I think everywhere in South Africa, we've got a very good program to test patients for TB. And I think our healthcare workers also do know that one risk factor well, anyone for good health need to be on antiretroviral therapy.
Yes, ma'am.
Okay, ma'am. Thank you. Thank you so much. Now we are moving to open house discussion session. Anybody who has some query with them can please ask here.
There is one question in the chat. Please elaborate immunization policy. As I told you that we do not have any immunization for TB for the staff yet. As ma'am said that in few years we may have some immunization policy for the pre-exposure of the TB. In future we may have, but at present we have for the hepatitis B and the tetanus, and we have annual screening for with the X-ray chest for TB. Annual screening for TB with X-ray chest. Anybody else? Any doubts they have?
Any queries? You have a wonderful opportunity to ask today. Any question regarding administrative controls of TB?
Okay, thank you, ma'am. Thanks a lot for giving us time and your this valuable sharing experience and knowledge with us. Thanks a lot.
Thank you everyone for attending this session. I hope no one has doubt here. Now we'll meet next month, last Friday. And please, I request all of you to give your feedback. You'll soon receive a link for sending feedback in the chat box. Kindly send your feedback.
Thank you, ma'am. We have a recording of this session, ma'am. I can share at the ETTI group also, or this is available with the echo also. We'll have the recording of this whole session.
Thank you, ma'am. Bharti ma'am, thank you so much for joining us. It's been a great opportunity for us to hear from you. Thank you all the learners. We welcome you again next month.
Thank you, ma'am.
Thank you. Yeah,
Thank you.
thank you so much.
Okay, ma'am. Thank you.
Thank you.
My pleasure.
Our pleasure too, ma'am.
Thank you all, and we'll keep the session running for another 2 minutes. Please submit your feedback, and I'll close the session in 2 minutes. You have the feedback link in the chat box. Please open the link and you'll go to a short form for you sharing your feedback. Thank you all. See you next month.
Thank you.